Okay, we're back on record at 12:54.
Okay, before the break, we were discussing the MRI scans that you had ordered prior to your office visit with Jeannie on January 15th, 2010. Is that correct?
Yes.
Okay. And you've pulled up the lumbar view of this particular MRI. What's the date on this MRI?
January 4th, 2010.
Okay. And what do you see here in this particular image?
This again is the lateral view. This again is a cross-sectional view. So again, we're seeing the entirety of the lumbar spine. Again, you see the tip of the spinal cord here, or spinal canal. You see the sacrum. This is our operative site. L4-5 disc, L3-4 disc. We'll go ahead and zoom those a little bit. This is a cross-sectional view. We can zoom. So as we come down past L3-4, you see that the L3-4 disc is now more narrow than it has been. There's now a very prominent herniation posteriorly, and as we come down, looking again at the cross-sectional views, we're going to see a change in the appearance of the spinal canal. So this is actually the disc herniation here. It's a central and more to the left. This is the left component right here. And this is actually the foramen that the nerve goes through at that level, which would be the L3 nerve root. You can see the L3 nerve root on the right side, but you really can't see it very well. It's compressed right here in the foramen at L3-4. As we go down, again, you can see the thecal sac compressed at L3-4. And this is a fairly significant change between the appearance of the L3 disc, L3-4 disc now compared to before. As we go further down, we're getting near the L4-5 disc. The first thing you see on the cross-sectional view is all of this out here, which represents a larger L4-5 disc herniation on the right side. Again, you see it predominantly off to the right here. And if we go over to the mid-sagittal section, you actually see it right here. So this is disc material that has actually squirted out of the disc. It's right up here. It's putting pressure against the nerve roots on the right, which would be the L4 nerve root and the L5 nerve root on the right side. So you go down L5S1, you'll see the thecal sac, which is a round appearance. You'll see a big difference in the way this looks as compared to above at L4-5 or L3-4. Again, a lot of room at L5S1.
Okay. And in making the comparisons between this particular MRI scan, you state that there is a significant change between what you're seeing here in January 2010 vis-a-vis the previous MRI scan. Is that correct?
Yes.
Okay. And specifically as we're looking at the L3, L4, and L4, L5 rows. When you say that there's a significant change from the previous MRI scan, what is the date on that previous MRI scan?
The date back to her first scan in 2007 in December, and then her follow-up scan in July 2008. Both of those show less of a herniation in both L4-5 and L3-4.
So the most recent MRI scan of this area would have been July of 2008.
Yes.
Okay, and what is your recommendation?
Well, I think that her symptomatic levels are certainly L3-4 and L4-5. I think that as time has passed for her, I think she's continued to have pain in both L3-4, L4-5 distributions there. So my recommendation to her would be exploration, decompression at both L3-4 and L4-5 with disc removals and antibody fusions.
In your opinion, did anything need to be addressed at the L5S1?
No.
You were pleased with the positioning of the plug still and the level of fusion, correct?
Yes, and the decompression.
And the decompression. And you base that opinion on what again?
Her clinical status, her radiographic x-rays, and her MRI scan.
When you say her clinical status, what exactly are you referring to?
Well, she does not have any evidence of S1 nerve root impingement or L5 nerve root impingement over the past 2 years. Now she's developing pain in both her right leg and her left leg, but has no S1 nerve root involvement. So I think that her S1 nerve root and her fecal sac are well decompressed, as evidenced by the MRI findings.
How can you?
that-
Oh, go ahead. I'm sorry.
I think that her pathology is at L3-4 and L4-5.
How are you able to rule out the S1 nerve root is causing the problem?
She's never had pain in that distribution over the past 2 years. In which her leg pain that she had preoperatively was basically much improved post-op. She never had any S1 nerve root involvement from the standpoint of her post-operative period. She regained her function in her plantar flexors, her ability to walk on tiptoes, and the leg pain was resolved over the past 2 years.
Okay. And do you have occasion to see Jeannie after January 15th, 2010?
No.
I'm going to take a look at some of these notations made by Babs, mainly for some clarification here as to what she's saying. Okay, I want to look at the April 28th, 2008 entry that she makes. And it appears that HEB was called, a prescription was called in for one or more medications to HEB, is that correct?
Yes.
Can you tell me the procedure for calling in a medication? Does that run through you?
Yes.
Okay, so if a patient calls in and asks for additional medication, what's the next step? She talks to Babs. What's the next step?
Babs talks to me. We talk about what to call in, and she calls it in.
Okay, that's indeed what she's noting here. She did. We presume that she talked to you and that she called in with the prescription to HEB, right?
Yes.
Turning, got a page in between, but it looks like you turn over a couple of pages and you see a whole slew of July 2008 entries. Do you see that?
Yes.
Okay. What is the date on the top entry?
July 21st, 2008.
Okay. Can you go ahead and read what Babs wrote there?
Patient's husband called, was in the shower, turned, got a catch, pain on the right side. He had to help her out of the shower, gave her 2 dark sets. She's laying down on Celebrex and Robaxin. Dr. N said to start Medrol dose pack, take as directed, call to HEB 687-1072, spoke with Mary, signed V.E. Babzell.
In your opinion, is this catch or this pain on the right side, what would it be related to?
I believe we describe that a while ago as musculoskeletal, muscle spasm, inflammation, irritation. Pretty common in the immediate post-op period.
And even over 3 months post-op, is that still considered immediate post-op?
Yes.
I guess on the next entry is from the same day, and it appears that Jeannie is called in and is saying that she can't move and she can't get out of bed. In your opinion, it's still musculoskeletal related and not uncommon for a patient in presenting in Jeannie's situation?
Correct.
It was a different day, wasn't it?
Well, I thought the first note was from, I've got a staple running through my date here. What is the date for that first entry on the page?
July 21st is 2008.
And then the second one is?
Same date.
Same date.
Okay, I apologize. I was looking further down the page.
Okay, and looking at July 24th, 2008, it appears that Jeannie's still suffering from these same symptoms that she first called in on July 21st about. Are you surprised that her symptoms are lasting 3 days?
Again, I'm not surprised here, but I think that was time there to move on to looking at x-rays and MRI scans, so that's what we did.
Now, with respect to it's your testimony that the positioning of the cage is never migrated, correct?
Yes, correct.
So even with the fall that Jeannie took, is it your opinion that the cages did not move as a result of the fall?
Correct.
Yeah, is it possible that interbody fusion cages could migrate as a result of a traumatic fall?
Yes.
But in Jeannie's instance, they didn't.
I didn't see any evidence of that.
You want to leave these films up here?
No, you can go ahead and turn it on.
That's good.
manual. Okay, now, as I referred to earlier, your attorney, as part of responses to written discovery, sent over a Verilift surgical technique manual from the time period when Advanced Spine had the rights to the OTI bone plug, or the Verilift, as they were calling it. Do you consider this technique manual to be authoritative?
No.
Okay, why?
Well, I had nothing to do with writing that at all. This is produced by Advanced Spine for their study. There are certainly some techniques in there that are described that I don't agree with, and we've altered. Mainly the fact that at that point in time, they were using the drill to actually remove disc material. They were not carefully trying to preserve the integrity of the vertebral body end plates. So there are definitely some differences in our technique these days as compared to them.
All right. Let me read to you from a subsection entitled Preoperative Considerations. It's on page 14 of this manual, and tell me if you agree with these statements. Exhaustive conservative measures should have failed prior to considering this procedure. First of all, do you agree or disagree with that?
Well, let's just say that this was the format for the study. So these are patients that the requirements, those were what they needed to have to document everything for the study beforehand. So again, everything you're reading here was designed for the study itself there. So I think there are some things that we do and do always, and some things in there that we don't do always. But certainly we want to be sure that we exhaust all conservative treatment measures before we do anything surgical.
Okay. So you agree that there is some parallel, or strike that, you agree that it would have been within the standard of care in treating Jeannie to have exhausted conservative measures before recommending surgery, the first surgery that you recommended for her, correct?
Correct.
Okay. You believe that all exhaustive conservative measures were tried and failed?
Yes.
There's a, and I understand with the caveat that you've explained to me in terms of why this is not necessarily relevant to what you do today with the Verilift, but there is a section on repositioning or removal of a cage when it becomes necessary. In your opinion, when is it necessary to remove or reposition a cage after you've actually implanted it?
The only time we've ever had to actually remove one is if we did not get a tight fit with the first device that we put in, and we can collapse it, take it out, and replace it with a larger device.
Okay, and you have done that before?
Yes.
And has that been?
In the operating room at the same time
Okay.
that the initial procedure.
All right. Have you ever had occasion to go in subsequent to that initial surgical procedure?
Not to reposition a cage, no.
It's never been necessary?
Not for me.
How invasive of a surgery would it be to go in and reposition a cage?
Well, you'd have to reopen the incision. You'd have to be careful to delineate the nerve sac and the nerve roots, and be sure that you protect them as you dissect them off of the devices and the spinal canal. Certainly there's going to be some scar tissue between the dura, or the thecal sac, and the wall, the lateral wall of the spinal canal and the floor of the canal. So the dissection of the nerve sac away from the bone and away from the floor of the canal certainly would be something you wouldn't want to do if you didn't have to.
And does it become more difficult with the passage of time in terms of going back in and repositioning or removing a cage?
Over the first 12 to 18 months, I think it is a healing process. After that, from 18 months forward, it would be about the same.
Okay, you're aware that you've been designated as an expert witness in this case, correct? In other words, you have been designated as someone with the qualifications as a medical doctor who specializes in neurosurgery. And because of that designation, you give, if the court will allow it, you're more or less asking to be considered an expert in front of the jury. Do you understand that?
Okay.
Okay. And as part of written discovery responses, your attorneys gave us a synopsis of what expert opinions, or the general synopsis of what opinions you may hold as an expert in this case. Let me go ahead and read to you what the substance of these opinions are. The general substance of Dr. Neely's opinions and impressions is as follows. The diagnosis of L5-S1 disc herniation was accurate. The surgery performed was appropriate and performed without incident in accordance with the standard of care. Mrs. Cook had an uneventful postoperative recovery, achieving the expected improvement in her symptoms and neurological function. The fusion did mature, her S1 nerve root symptoms resolved. The cages did not migrate or cause nerve root impingement, and the subsequent surgery removing the cages in L5 at L5 was therefore unnecessary. Okay. Do you agree that that's an accurate synopsis of the substance of your opinions in this case?
Yes.
Okay. Okay, when you state that Mrs. Cook had an uneventful postoperative recovery, what do you base that opinion on?
On her repeated visits to the office, the fact that she improved significantly postoperatively from the symptoms that she initially presented to office with, her back pain, hip pain, that sort of thing. She certainly had other reasons to have some of that continuing that she'd had preoperatively, but her symptoms from her L5-S1 disc herniation and S1 nerve root compression at L5-S1 were relieved.
Okay, and you state that the cages did not migrate or cause nerve root impingement. Now, what can you point to that's an objective finding? Be it a radiograph, CT scan, something along those lines, that can definitively show that there was no impingement of the nerve root by way of the interbody fusion cages?
The best study that we have is the CAT scan done in March of 2010.
Okay. Why don't we go ahead and pull that up?
Can we go off the record?
You want to go?
Can we?
Yes.
Yeah.
Sure.
Yeah. We're going off the record at 1:20.